you. Hurrah. So we've got a hand up already from Steve Turnbull. Hello, Steve. You're keen to get in there.
I am, and then I can give floor to Colin. But I just wanted to just mention, because obviously we've been doing these calls all the way through COVID. And I think it was on Friday that the World Health Organization announced that COVID was no longer being treated as a public health emergency across the globe. So since we're meeting today, I thought it was worthwhile just acknowledging that. Doesn't mean to say it's gone away, it's still there, but it's been treated like any of the other infectious diseases. So it will occasionally may cause an outbreak or a new wave, and we'll continue to monitor any new strains and any new guidance. We can obviously come back and share that in future. But given that there was that announcement from the World Health Organization, I thought it was just worth mentioning just before we get started. I'll go quietly into the background.
Very timely. Thank you very much, Steve. Thank you. So I'd like to welcome Dr. Colin Spears. And as you know, Dr. Spears has very kindly joined us. This is his second time with us because he did help us out about a year ago, maybe it's a little bit more than that. And it's in response to some concerns that we'd received about accessing primary care. So I've forwarded the concerns and information that have been provided to Dr. Spears so that he's got a bit of an idea about what you'd like to raise with him. So over to you, Dr. Colin Spears. Thank you.
Hello, everyone. Thank you for having me. So just for background, I'm a GP in Wakefield district in the northern, Castleford, Ferrybridge area. So I'm part of a practice called Healthcare First, but also I spend part of my week working for West Yorkshire Integrated Care Board. So that's the organisation that's responsible for coordinating and commissioning care or healthcare and other forms of care across the Wakefield, West Yorkshire area. And I work for the Wakefield team. So I work with a team that are responsible for monitoring the quality and development of general practice in Wakefield. And I think it's fair to say that there's been a considerable development in general practice. It's very different now than it was even before COVID, and that can sometimes be both difficult to navigate and understand why what's happening is happening. And you'll have all probably seen plenty of announcements from the Prime Minister in the last 24 hours around some plans that have been released at some stage today around how general practice may be asked to alter ever so slightly further. I think I was supposed to be joined by a colleague, and just checking he's here, Chris. So the colleague that I'm joined by is Chris Skelton. Do you want to introduce yourself, Chris?
Yeah, thanks, Colin. Apologies, I'm a few minutes late, everyone. This is what happens when you put somebody who's used to working on Microsoft Teams every day into a Zoom meeting. So I feel way out of killer on technology, which is not like me at all. So thanks, Colin. My name is Chris Skelton, and I'm the Associate Director of Primary Care for Wakefield, working as part of the West Yorkshire ICB. We have prepared a bit of a presentation, some slides to go through today. Would it be helpful for us to do that first?
That's fine with me. Were you asking Dr. Spears, though?
I think it's more everyone else, but yeah, no, that should be great.
Thank you.
Just checking everyone can hear things okay. Yeah, Chris, you're a little bit quiet. I don't know what's happening. I'm probably too loud, is what I'm assuming from that.
Is that any better?
That is better.
Yeah. If for whatever reason I start to go quiet again, just shout up, and I might have to hand over to you, Colin. But yeah, I'll do my best. I don't know if it's whether I'm not just speaking loud enough. Who knows? So Darsha, I've just sent across the slides to you. Have you got them? Are you able to share them on screen?
Can try my best.
Thank you.
But they are not in my inbox, Chris.
Okay.
The joys of Zoom. I'd forgotten that when we first started COVID champions, Zoom was the main way. We didn't have Teams then at the council, and we had to get everybody to set up meetings on our behalf. So we were way behind everybody else. But now Zoom seems really quite different to Teams.
It's strange.
Yeah. Whilst we're waiting for the presentation to be sent to Dasha and to load up, there's a comment in the chat, as well as some people saying that they were finding it difficult to hear. But somebody else had also said that they couldn't praise Outwood Medical Centre enough, never had an issue. And Health Watch have sent me some information, and there's been a very mixed bag about certain people having good experiences and then others saying different. So it's not all one way. Oh, well done, Dasha.
And I think that's a reasonable statement. So there are areas of outstanding practice within the district and other areas where practices are improving. But that's across the board. So some practices can have amazing access, but there are other areas that they're looking to improve upon. So and all of our practices in Wakefield are slightly restless, and they're always trying to look at how they change and adapt to new requirements, both required by the population that they work with, or by the contract and national edicts from the likes of Steve Baker. Chris?
Yeah, I'm back with you. Sorry. If I can have the second slide, please, Dasha. So, here we go. There we are, back in business. So, just to give you a bit of context, as Colin was just saying, actually, interestingly enough, in Wakefield, we're in quite a strong position in terms of access to general practice. And I know it might not feel like it, but what we'll try and do today is just share some of the context around some of our numbers. And today is actually quite timely, because as Colin's already mentioned, the general practice recovery plan's being published. And obviously, there's a lot that's in the news about it. So you can ask me if you want to, because I'm not sure we've got some time for some questions about what some of those numbers might mean for Wakefield, in particular some of our GP numbers, etc. So we can share that. So we have got 34 general practices in Wakefield, and that's spread across 52 different sites. So although we've got 34 practices, we haven't got just 34 locations. And our practices are working together in groups, basically, what we call primary care networks. And they do that not only working with each other, but working with other providers such as community services, social care, etc. So you might have heard about primary care networks before. I'm sure some of my colleagues have been and talked about it. But I always think it's important just to kind of reiterate what they are. Again, happy to ask any questions on that. In terms of the size of our practice, and by size we mean how many patients do we look after, we've got quite a variation. So we've got a practice that's got just over 2,500 patients, and we've got one that's got nearly 32,000 patients. And we've got really good coverage of practice areas across our district. So we're not a particularly rural area, which means that patients have often got lots of choices about which practices they register with. What we do know, and again, you'll have seen this, the number of patients that are registered with each practice is continuing to increase. That's not only in Wakefield, but it's happening right across the country for various reasons, whether that's because practices are closing or for other reasons where practices choose to come together, usually to make themselves more sustainable. And in Wakefield, that's the kind of common reason. We've not been in a position where we've had to close practices, or practices have kind of, said to us, we can't deliver anymore, but it's mainly been through maturing relationships and people wanting to work together to improve this.
Chris, I think we've lost you.
I was wondering whether it was my headset that had gone faulty.
Can you hear me still?
You disappeared for a second.
Can I have the next slide, please, Darker? So in terms of appointments then, because that's the most common thing that people always ask us about, we do monitor this regularly, and there's a national set of data that's now published, and often you'll have heard about it, you'll have read about it. And the key highlights to take away from this really is that when we compare ourselves to pre-pandemic levels, we're providing more appointments than we've ever done before. We know that there was a slight dip in the number of consultations that took place during the pandemic for obvious reasons. We know about that. But what we've seen is our recovery has not only beaten what we were doing previous to that, but it's gone above and beyond. And actually, one of the tools and metrics that we use is we compare how many appointments we provided for every 1,000 patients, and it helps us to compare how we're performing as a district with that of other districts across West Yorkshire and across the country. And when I mentioned at the beginning of the presentation, I said we know that Wakefield's performing well. This is one of the reasons why we know we're performing well, because we provide about 520 appointments for every 1,000 patients that we have in the district. And that means that we're 8th in Yorkshire and Humber, and we rank 12th nationally out of all of our areas in terms of the number of appointments that we're providing. That's not to say it's necessarily that we've got too many or that we've got enough. It's just an indicator of how much activity we're doing on behalf of patients in Wakefield. Can I have the next slide, please? And what we'll do is we'll send these slides out, but these are just some of the numbers that help you to look at. The blue box is the overall total appointments, and that's done by anybody, whether that's a GP, a nurse, a pharmacist, and that's giving you an idea of how many appointments are provided and how we compare against the rest of West Yorkshire. We have provided the orange box, which tells you the number of GP appointments, so appointments just with a GP, and what that looks like. And you'll see that we had a recovery following the pandemic in 2020, 21. And you'll see that between 21, 22 and 22, 23, that's quite flat line. And that's because what we're not seeing is an increasing number of GPs. It's in the news today, the number of GPs that we would like to have, not only in Wakefield, but right across the country, is not where we want it to be. So we're doing well in Wakefield in terms of retaining our GPs. We're not losing doctors, but we are gaining, and the people we are gaining are newly qualified, and they take more time to train. They don't provide as many appointments because they're not as experienced, and it does mean that our experienced GPs have to spend time supporting our newly qualified GPs. So that's why it is an increase. It's still just under 1%, but it's not certainly keeping pace with the increase in the population. And then what we've provided at the bottom as well is the number of appointments that are provided and how we compare across the district. Dasha, next slide, please. So how many doctors do we have then? How many GPs? 246 whole-time equivalent doctors, and we have got 22 more than the baseline that was set back in 2020. But the vast majority of those 22 are actually GP training. They're doctors in training to become GPs and not yet fully qualified. We have 150, just under 150 qualified nurses, and that has reduced since 1920. And then we also have seen a significant expansion in what we call direct patient care roles, and they're people like pharmacists, physiotherapists, and other colleagues that are paramedics, the list is endless, that help our practice to provide care to its communities. And that's where most of our government funding has been targeted, and where our primary care networks that I mentioned at the beginning of the presentation have started to come together to share those staff and also to develop them into roles in primary care. Next slide, please, Asha. So we know that access in general practice is one of the biggest concerns, not only for Wakefield, but it's on everybody's lips. It's often in the press, and unfortunately not for good reasons. And the reasons are multiple, complex, and political at the same time. So again, we might want to ask you a few more questions about that. But what we've obviously mentioned is that there is a GP recovery plan, and we'll be responding to that as a district, and already started some of the work to help improve it. So we have got plans in place to help practice to increase capacity, ultimately to try and improve patient experience and the quality of care that practices are provided. And there's a couple of ways that we've started to do that. So the first one is that we started to work on our telephony data. So we know that patients, the most common reason that people get frustrated contacting their practices, ringing up for an appointment and getting through to the receptionist, and the whole process that go through with that. So we've already started gaining some of the information that helps our practice to understand how to use the phone systems, and learning from practices where things are working really well and patients are often commenting, we have no problems getting through on the phone in this practice. What is it that we can learn from? What is it that's working well? And how do we repeat that? And where it's not working well, how do we support those practices to make improvements? We also have our community pharmacy consultation service. So this allows patients to access care for straightforward things, straightforward complaints by the most appropriate professional, which in this case would be community pharmacy. So we've got established relationships now with our community pharmacy colleagues to be able to deal with straightforward stuff, and we will signpost patients to those services appropriately. To be fair, we've been doing this in Wakefield for quite some time. We call it care navigation, and actually it's now being picked up as sort of a nationally recognised model to support receptionists or care navigators to ask more questions about what patients are contacting us for in order to direct them to the best available service for them. So we'll begin to see more of that, and that becoming much more of a standard access model across the country. And also just learning from the COVID-19 pandemic and our vaccination programme about how we can do care or deliver care in communities, really. So accessing more people who wouldn't traditionally come to a general practice and trying to support them to reduce some of those barriers to inequality by delivering care in locations that suit them and are more likely to engage with relevant trust and support from community leaders. And some of that is where you guys come in to help us to support. Next slide, please. So we've included just a couple of things and examples of what we are doing. So there's significant promotion really about how to contact your practice. Most people think you can only ring up on the phone. Most people think that you can only ring up at 8 o'clock, and most people think you have to ring up every day to get an appointment. And the frustrating thing is that at the minute, that's different in every single practice. Every single practice has a different system. Some of them work really well, and some of them patients find particularly challenging. What works in one practice doesn't necessarily work in another. So there's no magic science to any of this. I've been working in primary care for just over 20 years, believe it or not. And we talked about access the day I started, and we're still talking about it now. It is multifactorial, it is very complex. And the best thing that we can do is to support our practices to work with their patients and with each other to find out what works best for them, and accepting that what we do today might be different to next week and ultimately to next year. So we need to keep on top of it. We will be promoting, however, alternative routes for people who can use them. So the most common method, about 95%, probably slightly more, of people who contact their practice will do so via the telephone. But not everyone needs to do that. But what we haven't done is tell people what the alternative methods are, and particularly what we've seen, and it mainly came through the pandemic, but has continued since, is online. So people using things like the NHS app to send messages to their practices, to send what we call online consultations, which is a brief description of what's wrong and what it is that you need, to have a clinical response or an admin response back from the practice. It's more convenient for some people. It means that more people are more likely to access our services, and helps us to structure it to try and tackle some of that 8 o'clock rush in the morning, which most people, particularly for people like me at work, that might not be a convenient time for me to be able to get through to my practice. And we've also been working with some of our practices. There's a couple of real examples from Wakefield to promote on social media some of the work that they're doing, some of the improvements that they're making for their patients, and also to signpost us other services that are available within that community to be able to support. And we'll be encouraging more practices to take on that approach so that we can share learning. Next slide, please, Dan. So this is just an example of some of the work that we've done around our practice telephone systems. We were really surprised to see the significant variation in these are kind of samples really from Wakefield practices, and there's a significant difference in the number of people who contact their practice. So when we proportion it out, some practices have a lot of people for whatever reason who actually ring their surgery, and others that might be of a similar size have far less contact on the phone. So we've been doing some work to understand why that might be. Is that practices are asking patients to ring back for appointments and therefore in effect doubling their workload? Is it the systems that they've got? Is it by implementing online consultations they're helping to reduce that burden? And there is some evidence that using alternative methods has helped us to do that. But there's still more work to do, and this will be a continued focus for the next 12 months. It's also worth mentioning, you've probably seen it again on the news this morning, there's national funding now available to support practices to move away from analog phone systems, traditional phone systems, to cloud-based systems, which allows people more flexibility and more people to contact the practice without necessarily getting them engaged to them, etc. Next slide, please. So what are we doing to work with patients to improve access? These are some of the 7 steps that we've developed, and we've used these slides to work with our practices and our primary care networks. These will be added to and changed. And again, people might have some feedback for us today about what things you would want to see us include in terms of how we work with patients to improve access. So what we do know is we need to act on patient feedback. There's no better measure really than understanding what people are saying about each practice, what their experiences is like, and also what some of the measures tell us, whether that's family and friends tests, what's on social media, and then what information the practices are able to gather. We also need to make sure that we balance that, because as a patient who might use GP services a lot, you equally don't want to be asked repeatedly to give feedback on the services. So getting the balance right is important. We also need to make sure that we consider that we need to work with different people, that, you know, we have to provide a universal service in general practice for everybody, cradle to grave, but yet people's needs are different, people's experiences are different, and there's no one size fits all. And usually with appointment systems, it is a one size fits all, and that's a really tricky balance to get right. We do need to utilise our social prescribing link workers to help patients to access other points of contact, whether that be digital resources, it might be community services. There's lots of things out there that support people rather than just needing your GP practice or your GP, but we need to make it easier for patients to find it, and it's got to be tailored to them. And ultimately, they may still have a medical need that we need to be able to support them with. We've got care navigation and customer service training for our receptionists and reception staff. So we work with our GP Confederation to provide that. We provide that training and support to other areas right across the country. We're really proud of that. But what we recognise is it's not just about asking questions about what's wrong or how can we help, but it's also about giving people the right customer service skills. The receptionist is often the first interaction that patients have with the NHS, and we need to make sure that we get that right. And we can only do that by supporting them. We have a very complicated role. It's a very busy role and a very demanding role. And retaining staff in that sector is becoming increasingly difficult, and as people take up other opportunities. So we do need to support them. We're including, you said we did notice boards. Patients comment often that they like this. They like to understand, well, where's my feedback gone? What have you done about it? And what improvements have you made? And to be fair to our practices, they've done a lot of work in terms of improving experiences for patients. Last year, we've got a report actually from every single practice about the improvements that they've made in their patients' journeys. And there's some cracking examples of things that they've done that have made a real difference to people. But we're not telling people about it. We're not promoting it. I think, to be honest, we kind of think, oh, it's the right thing to do. And there's been lots of these programs happening for a while. But we do need to get better at saying we are listening and we are doing as a result. But there's no overnight fix. We need to promote more self-care and direct people to where that is, so that they understand what's available and how to access it, and work with patient participation groups and other community groups to listen to feedback and to understand them ultimately. Next slide, please. And just a quick plug for those of you that don't already know, are people familiar with the GP Care Wakefield service? People have heard of it? I can see a nod. We're really, well, in summary, this provides appointments on evenings and weekends. We're really lucky to have this service. In Wakefield, our practices all work together to provide this service so that everybody in the district gets an equitable access. We provide care at evenings and weekends across 5 sites across the district, so it's not in every practice, but it's available to every practice. It also helps support us when pressure's been really tough, particularly winter pressures where the hospital's been under a lot of pressure. You access this through your existing GP practice. So if you do want an appointment at evenings or weekends, whether that's for a doctor, whether it's for a nurse, or whether it's something urgent, the service is available to you. And like I said, just asking practices. Next slide, please. We also have the King Street Walk-in Centre. Most people will be familiar with that, but it is open 7 days. And again, available to all patients within the district as well. Next slide, please. I just wanted to end really on the COVID vaccination programme. So again, this has been running since December 2020. I was lucky enough alongside Dr. Spears and a few others to have been there at day one really, and since that time we've administered over 1 million doses of COVID vaccine to our Wakefield district. It will be much more than the numbers on the slides now, given that we're in the spring vaccination campaign. We've consistently exceeded the West Yorkshire and national averages in terms of vaccine uptake, and we're really proud of that. And we work with our GP practices through our primary care networks to make sure that we're delivering vaccinations to those who need it most. And we try to target that vaccination to those who are at greatest risk, particularly our housebound populations, our elderly populations, and those with underlying health conditions that we can't where our immune systems don't quite work as they should. What we've also seen when we look at the numbers is our uptake in care homes has been particularly high, and I was really chuffed because we just started actually a couple of weeks ago vaccinating patients in care homes, and we were first past the post in West Yorkshire to visit every care home. So we're really proud of that. We're now, in terms of the spring programme, we're now into getting into the over 75 cohort and the sort of wider group that's about eligible for vaccination, and that will come to an end at the end of June for patients. And there will be an autumn campaign. We've not seen all of the details yet around that, but we're performing well, and that's on top of the appointment numbers and the day job really. So we'll end the slideshow at that point. I'm sure lots of people have got lots of questions, and I hope I didn't canter through all that quickly, but I just think it's helpful for people to see some of the context of what we are doing and the narrative that is really important, really, because like I said, we're lucky to have what we've got, but we recognise there's still lots of improvements.
So I think the take homes for me from that are always that every 2 months, general practice offers enough appointments for every single person in Wakefield to be seen, and that 75% of the appointments are face-to-face. That there are multiple routes into general practice now, and that can bring a degree of complexity for some, but the traditional route of the telephone or walking in is still there. And that when you're seen in general practice, it is likely that you're going to be seen by one of a number of different healthcare professionals, be that a clinical pharmacist, physiotherapist, mental health practitioner, dietitian, nurse, ANP, ACP, etc., advanced care practitioner, advanced nurse practitioner, paramedic, GP trainee, trainee nurse associate, nurse trainee, so that there is a wide healthcare assistants, healthcare support workers. There's a wide range of people that we're trying to navigate individuals to that present to make sure that you're seen by somebody that's appropriate to provide the care that you require, but also to free up capacity for those that require more complex care to be seen by people that can manage more complex cases. And as a consequence of an expanding workforce, but also dealing with expanding demand and the different levels of complexity within that demand. And I think nationally, I would say that this is a way of delivering care that's been put forward nationally. So NHS England, Department of Health and Social Care are the people that instigated this. They haven't necessarily done the best job of describing it at a national level in that promotional work. There's been some promotional work done by across West Yorkshire, but it's quite easy for that to be lost in also all the media accounts of the access challenges, which are real. I'm not going to deny them, into general practice as well. And I often, worry for parts of the country where appointment levels are significantly lower than they are in Wakefield and West Yorkshire, where I've seen numbers that are half of ours. So I can see that there's been some comments coming in. So points of contact, yes, that's a really good point. So there's a message here from Lindsay saying that all those alternative contacts are great, but actually knowing where to look for them and them being easy to find when you go is important. So I would say to anybody, if you haven't got the NHS app get the NHS app, because actually it's the easiest route. So if you go into the NHS app, and this is how I do it with my own GP, there's a section on messaging your GP. For all of the practices in Wakefield, apart from 2, this is live, and it should be live across all of them shortly. But that allows you to fill in a very simple form that goes to your GP practice, where it can be checked and triaged and sent out. You can use that for multiple different things, such as admin access. So if you're wanting to chase up what's going on with a referral or a report, if you're wanting to request a continuation fit note. You can also use the NH app for requesting repeat medications or another issue of a medication that you've had in the past, and of course making contact about a condition that you've had or some new symptoms that you may be experiencing. And then that is triaged through the system within practices and sent to an appropriate person to respond, or an appointment where usually an appointment can be booked from that as well. So if you can't use the internet or a mobile phone, you can still phone a practice in the same way. And actually, the aim with this is that the more people we can get to use online services, the better we make access by the phone for people that rely on using the phone as a way of contacting. So for somebody such as myself, I'm a 44-year-old, au fait with technology, I can quite easily use that. But there are other individuals that may have coordination problems, visual problems, or just don't feel comfortable using the technology and don't prove it. The way we can improve access for them by telephone is trying to remove people from, like me, who can use other means of getting access. And if I've got something more complicated, often the practice can phone me back, because I'll say it's a bit complicated to write. Can you call me back for an appointment, please? I'm trying to keep track of the chat, but it's quite hard. So I'll hand over to Tracy, to chair and bring forward questions.
Thank you very much. Well, I'll let our champions who are on the call, if anybody there's got any comments or questions they'd like to raise, please. I've got a few that we've already sent to you, Colin, haven't we? But I'll let those on the call come forward if they'd like to ask a question. Just shout out, guys, because I can't see if your hands are up.
Yeah, I'd like to ask a question, please. Can you let me know are there fewer no-shows because it is difficult now to get GP appointments?
Great question.
So the DNA rate, the do not attend rate for the district usually runs at around 3%. Generally, we find that the further away you book the appointment, the higher the chance of not attending. Also, factors such as being young make that less likely. And if you book that appointment due to a one-off condition, you're less likely to attend as well. Practices generally don't overbook because of the fear that if everybody turns up, unlike a plane, we can't just offload you. And we don't want to worsen the experience for individuals, as well as creating some burnout pressures for staff. So it is a difficult thing, but you're right. We have seen a slight reduction in do not attend rates from before COVID, when sometimes it could run as high as 6%. But that's quite a significant number of appointments when you scale it up across the whole of Wakefield, and it's a tremendous cost, really. But there are ways of cancelling appointments if people can't attend as well. So often practices have got, you can just reply to the text message reminder or phone, although I appreciate the phone can be an interesting challenge for all of us when we try to use it.
Thank you. We've got a comment from Jill. She's put, lots of the patients I see, cancer patients, want to see a GP and don't understand about the other roles, and they feel fobbed off if they don't see a GP. There's little information, and I can't see what else she's put after that. But could you comment, please, about people feeling fobbed off if they didn't actually see a GP?
Yeah, I mean, this is difficult because there's a change in the way that care is being delivered, which is for the best of intentions. It's not trying to fob people off or cheapen the experience. It's that there are some times when you're better seeing somebody that isn't me. if you've got a sore shoulder, you are far better seeing a physiotherapist. If you've got a mental health condition, you may be better seeing a mental health practitioner. So these are people that have, you know, undergone 3 years of specific training around those areas. For complex kind of problems that involve lots of different health conditions, I'm great at that. But if you are requiring, let's say, an annual checkup for your diabetes, our practice nurses do an amazing job at that and provide very holistic care. So it is the right person for the right time. And it's, I think the bit that has been missing is the explanation, the marketing campaign, the national messaging around the different roles and what those roles provide. A lot of them are, you know, they are all very highly trained professionals that deliver different things. And just like in a hospital, when you're undergoing cancer treatment, you often see a cancer nurse specialist. There's no reason why similar roles like that we can't consider some of the roles that aren't doctors in the same way in general practice as well.
Thank you. Pete Taylor's got his hand up. Have you got a question for us, Pete?
Well, question/discussion. I've spoken about this, Colin, with our local doctors, and I'm one of the patients group, various other bits and pieces as well. And I know, such as my mum, and there are people around that really struggle with this. And one of the things we talked about is stop calling them receptionists. People don't want the receptionist triaging them, you know. And that, like you say, I completely agree that explanation that you're talking to some kind of triage clinician, and it's not an appointments line, you know, it becomes, because if you call it an appointment and call it a receptionist, it's going to be very difficult to get that message across, because they phone the receptionist for an appointment, you know, it follows, and they want a doctor. But if they know when they start that what they're actually phoning is the technician, the clinician that's going to triage them, that they're doctors, who's going to point them in the right direction, like they did to me a couple of months back. It works brilliantly once you've got your head around it. So the question is, how can we get that message across to people who are 60, 70 years old, who've seen this system working all of their life and now don't understand how and why it's changing and don't have a smartphone and internet? You know, I don't know how we get to them, but that, like you say, that's the way to do it.
I think that's a really important point. So I remember having a conversation with a local councillor, and who was saying that he dropped in to see his practice one Monday, and was stunned at the fact that they had 1,000 calls, that morning. And I think general practice isn't what it used to be. So, you know, people are quite, you know, when they picture general practice, they probably picture something from the kind of 1950s, 60s, which is, you know, going in, speaking to somebody that you're familiar with, who's sat behind a desk, that writes your name in a book, and may occasionally pick up the phone and answer it whilst you're there. And that isn't the face of general practice at all, and hasn't been for quite a while. So often, GP practices are running small call centres that may have, 4, 10, 12 people in. People on front desks are often handling difficult problems, just like people are on the telephone. And you're right, it's that concept of a receptionist and appointment line, when in reality it's care navigation and patient services, and it's how we change that narrative and make it so that people still understand what it is. Because if you phone, let's say, BT, you expect to, that you're going to speak to a customer services representative. How do we embody that within general practice to say, when you phone us, you're going to speak to a care navigator who's somebody that's been through training to understand how to navigate your care to the appropriate person, and who to escalate it to if there's a problem. So when I'm sat in my practice and I'm the duty doctor, I'm sat in the call centre with all the staff, and they'll be coming over to me asking me questions all the time. This person's got this. I think is that correct? Or they've said they've got this pain. Do I need to be worried? I'm like, well, yeah, you're right. That does sound like chest pain. That as a general practitioner, we should only be seeing if we know that you're not having a heart attack, and we can't rule that out. So it's a highly complicated thing that they do now, and we need to kind of try to embed those language and take us, all of us, through the journey of changing the title and the expectation. Because I've spoken to my own staff to say, you know, what would you like to be called? And they're not clear themselves either. Because they say, well, the patients know that I'm a receptionist, so why make it confusing for the patient?
Yeah. But when it works, like it works at my practice, it works incredibly well. If you go along with it, it's brilliant. It's just like you say, it's new, it's different.
And it was it's really important about getting that message across in the right way to the right people. And I think that's possibly what Lindsay might be putting her hand up, because I know she's put a comment in the chat. Is that something you'd like to speak about now, Lindsay? Oh, she's gone. Where has she gone? Lindsay had put in the chat, I think it was in a response to Chris that had said something about a national campaign. And oh, she's here. We can't hear you. She's going to keep trying. Oh, sorry about that, Lindsay. Manira, if you're on the call, can you see if you can unmute Lindsay from our end, please? You just click on the unmute button, I think. I'll go back to the chat because she put something about the Recovery College has a fantastic newsletter, and it's one of only a handful that I actually read, because I get loads of, as a networker, I get loads of stuff you can imagine, but I nearly always sit down with the Recovery College one with my cup of tea and I read through that. It's a great one, and a lot of people print it out and take it to groups and share that information. And they actually host now the Positive Mental Health Network newsletter, which goes out to 200 people via email. But what we ask people is, if you can take it to your group as well, and please share it with your group members, there's information in there. So if there's anything around a national campaign, or actually some of the really excellent work that's gone on that we don't always know about, that we've heard today in this presentation, some snippets of information like that for people to read might just help to reassure people that actually, you know, you might have had a negative experience, and we're not diminishing that, but actually look at some of these statistics, how Wakefield is doing really well, and we are still working to improve that. Those kind of messages I think will be really useful. I'm sorry, I don't know why she can't join the call.
So just want to comment. So Jan's mentioned the role of care coordinators for people living with dementia. And I'd say actually other long-term conditions. So care coordinators is probably a new role that many of you may not have encountered before. It's an amazing evolution in general practice. So the idea is that they work with a cohort of individuals that have a very similar, so that we may have I've got care coordinators that work with on safeguarding, vaccination and children's health. Others have got them for patients with cancer diagnoses, or end-of-life care, or those that have got dementia. And their idea is that they act as the person that glues everything together. So that, they're supposed to hold your hand as you're passed from provider to provider and organisation to organisation, to make sure that nobody gets lost in the middle, but also to develop that relationship, to provide some continuity as well. And they're a wonderful role that hopefully we're going to see more and more of as we start to deploy them into practices to deal with new areas. So I know that there are some that have got them for based around some long-term conditions as well, for those people that have particular difficulties with challenges. So people with chronic obstructive pulmonary disease or chronic bronchitis, they get lots of attacks across the year. So thank you for reminding me of those.
Thank you. We've got a comment from Ruth, and she said she's found it difficult to pre-book appointments. Lots of people with caring responsibilities struggle to call at 8 AM, but then they're told that the only way to get an appointment is to ring back the next day or later in the week. I've suffered that same that same frustration. So my GP is not in Wakefield though, but yeah, have you got a response for that for people who have got caring responsibilities?
Are you going to go, Chris?
Yeah, I'm beavering away at trying to respond to your comments.
Oh, bless you, thank you.
No, it's fine. It's really helpful. And what I was going to say is, what we do is, all our practices, the first thing I want to say is make sure you practice and not we've got good arrangements in Wakefield, whereby our practices will probably refer you to Carers Wakefield to make sure that you get access to all the advice and support. And every month, Carers Wakefield make sure that they give the information to practices so they can update their systems, so that We then work with our practice and encourage them to make sure that they are flexible people who have got caring responsibilities. That should be on your record. Practice should know when you contact them, you've got those responsibilities. It's probably not unhelpful to remind them of can't ring it, it's not anymore because I need to be somewhere, I need to look after that time. So they should be accommodating that particular need. One of the things that's changing in a minute is practices will need to move away from traditional appointment models where you're told to ring at a specific time. This is what the new plan is about. That's in the press today around making sure that it doesn't matter what time you ring your practice when it's open, you should expect to get the same level of response. You should be able to book an appointment, you should be able to get an appointment, etc. But we need to work with each practice because some have got that system working well. Some have got that system in place but don't have the capacity to be able to meet the demand that's on them. And some practices are really not doing that appointment system at all, but we need to support them and offer them a consultation program in order to adjust their way of working in order to can become a working.
And Wendy's shaking her head at that. I think she's put a comment there about having difficulty. Yeah,
major. I mean, all I wanted was a blood test. I phoned up in the afternoon and was told, oh, you've got to phone at 8 o'clock. Why? And that was the problem. I'm having quite a number of problems trying to get hold of appointments, etc., with GP. And it all seems to be telephone appointments. So, I'm really amazed that you've got 75% face-to-face because I cannot get a face-to-face appointment for my life. I just can't.
And several people have said that, Wendy. Others have responded to me and said they've tried days on end, and when they're like 64th in the queue, they think, well, by the time I get through, I won't have got an appointment now, so I'll try again tomorrow. I've heard of people using 3 and 4 phones, ringing up like a lottery.
Yeah, and that it's what I mentioned at the beginning. It's not great, and that's really what we're trying to tackle. Is to kind of it's as I said before, it's multifaceted. So just putting cloud-based telephony systems means that you might not get an engaged tone, but if we've not got the right number of staff and the right amount of capacity behind that system, make it work, we will get one number 110 in the queue, and that does. What we don't want is multiple people also bring on multiple numbers for the same appointment because it just increases demand that we're then trying to meet. Again, it goes back to digital payment options for some, and also making sure that where patients the kind of promise with the national promises around making sure where patients get an appointment in 2 weeks. There's a big cultural shift the practice has got to do in terms of from a quality improvement perspective. I'm thinking you're absolutely right, Wendy. You hit the nail on the head. Why have I got to ring at 8 o'clock in the morning? Why? And actually, a lot of it's because of the historical way in which practices have established their systems. And some practices have done a really good review. They've really logically worked through it. There's lots of support about it and engage with patients on how they make changes. But nationally, there's a lot of work to do on that in order to get it right. And then when we've got the system working right, it's making sure that the capacity behind it to be able to deliver it. So very much in the next few months, first part of this year, I'll be starting practice to review their systems and make improvements. But I fully expect we'll then be in a position where practice might not have a lot of the time to actually. That might be why we're asking people to be back up because they've got a bottleneck and they've got the capacity behind it in order to be able to meet it. It might be that it's already there, so there's a lot of work for us to do with a lot of practice to get that right.
But it's worth pointing out that this isn't going to be an elimination of phone queues. So the national target is an average call wait of 3 minutes, which compared to other sectors is actually quite fast. I don't know if you've phoned BT or Sky or anyone recently. It's quite long usually. And the real challenge is that there would never be sufficient capacity at 8 o'clock in the morning. So an average practice can see their phone kind of demand spike to kind of maybe 100 if they've got a 10 to 15,000 patient population. You're never going to have enough capacity to answer all those calls quickly. So trying to disperse that demand across more time is the best thing that we can do. That requires some challenges around altering access. So I know that, you know, when I'm sat in the call centre, I can, as the duty doctor, I can see that our queue has disappeared by somewhere between 9 and 10 o'clock often, which seems crazy when you're the person that phones at 8 in the morning and you get told that you're, you know, a millionth in the queue. And it's when you start to look at the numbers and try to understand why that's happening, it's really clear that there is, you know, lots of work to do to improve the experience, because it's not great for our, you know, our customers, for our patients. It's also not great for the staff either. So trying to make this work for everybody is going to be the best thing. So I can see that Michelle and then Peter have got their hands up.
Yeah, and can I just say first that Lindsay, who couldn't speak, has put something in the chat that I've lost now, but she basically said it would be nice to do a series of little articles in the newsletters for people to read, like a day in the life of a receptionist or a day in the life of, to let people know what their role is and to have a bit of empathy, see them as real people and that they're facing a challenge, you know, we're in it together. That kind of thing might be something useful. And yeah, thank you. Michelle's very patiently been waiting.
You're all right. I'm just aware of time as well. So I've had two things, but I might email you the second one. So yeah, it was a kind of a follow-up comment on that, really, and just my experience. So I think it's fab that there's other ways to, you know, access, and I'd requested an appointment through the website. I haven't had the appointment yet. It's actually tomorrow. It was almost a month ago that I requested it, and it's going to be a phone call. So kind of slightly frustrating that I know that I'm then going to have another face-to-face appointment, and there'll probably be other follow-ups. Yeah, so it's kind of annoying, really, that I used that system, because I thought rather than phoning at 8 in the morning and then I had to wait a month. And I had a question to put to you from one of my volunteers, actually, who couldn't make it today, but it's about annual health checks for people with learning disabilities. So, and because of the time, I might just email you if that's okay.
I think Dr. Spears should have had the email that was forwarded, I believe, about that. Am I right?
Yes.
Have you had it? Oh, fabulous.
No, I have had it. I was going to do some work with some colleagues that work in this area specifically to take on board, because I think there are really sensible suggestions around personalised health plans, which should be standard. But yes, we'll take that forward.
Fabulous, thank you.
Thank you. And just before we go to P, is it right to say now we've got you on from Health Watch that if people have got complaints, concerns, it's not about telling tales or getting anybody into trouble, but if we know what's wrong, we can help to fix it. So if you've got a problem or an issue, I know it's really hard, you know, and I'm a complainer. I think, oh, this is hopeless. But actually, if we let people know, this has been my experience, and then they can look at that. They can look at the services, which GP practice might need a bit more support. And then Health Watch send a monthly intelligence report of all this stuff to the Quality Improvement Group, which is part of the ICB, the Integrated Care Board. And I understand that the digital program manager has emailed Gary Jevon recently to say there's going to be some positive beneficial impacts on appointments, access to appointments coming soon, and hopefully there'll be some more to tell you that will be very positive coming soon. So I thought I'd mention that while you're on from Health Watch, so people know who you are and how to contact you. Thank you. Back to Pete.
Thanks, Tracy.
Pete, did you want to say something?
Yeah, I think the 8 o'clock rush is kind of a self-fulfilling prophecy, isn't it? You've got a limited number of appointments, and you will allocate them on a first-come, first-served basis. So everybody's going to phone up and try and be the first. You're creating a problem that you're trying to solve. And then the ones that don't get through have to try again the day after at 8 o'clock. You know, the system creates its own issues. Don't know what you do about it. But the question is, bearing in mind the number of people that try that and then hang up, or hear that the 25th in the queue and then hang up. You said the demand has risen 6%. How do you know what the demand is when you've no idea how many people give up trying to get an appointment or can't get one?
So you raise a really interesting point, because I think general practice regularly talks about capacity, not demand, because we can't measure our demand like a lot of parts of the NHS. So our capacity has increased by 6%. It would be a fair thing to say, and there will be unmet need. Increasingly, the phone systems that are going in are becoming more sophisticated, so they can track their abandoned calls, and they can track also how many times an individual has tried to call, which gives you some sense of urgency. So this is part of the quality improvement work that we want to do with practices, which is around how to use the reporting functions of their new telephone systems to be able to then see problems like that. So if someone's tried to phone 5 times that morning, I'm a little bit worried about what's going on there, and we should proactively be trying to contact them. You were also correct around self-fulfilling prophecy. So the reality is there is insufficient capacity in general practice to meet the demand that is there. There's no ways around that. And what we're looking at with all these various changes is ways of trying to triage and direct people to the right place. But there is a finite capacity. So what happens when a practice exceeds its capacity becomes an increasing problem, particularly when we're trying to endlessly balance same-day urgent access against long-term conditions and routine care, and trying to get that correct. And there is a feeling that the amount of same-day need has increased alongside an increasing amount of long-term care and routine appointment requirements. Trying to square that circle is going to require the use of all those professionals that we've got coming in and trying to, it takes a while to embed them into the system because they're new to general practice often, and get used to our risk appetite and our ways of working. But I can see that things are slowly improving, but I can appreciate it is frustratingly slow for those that use our services. As a patient, I get equally as frustrated as anyone else. I'm not registered at my own practice. I just wanted to come back to something that Jan's written, which is around morale in general practice, which I think is a really interesting question.
Lester, yeah.
No, thank you. So I would say that I'm hearing reports of people in tears less, but it still happens. So threats of sexual violence, murder, and other forms still happens, particularly to our most frontline staff, which is our care navigators or receptionists, who have incredibly difficult jobs. But most people are really understanding and appreciate that everyone's kind of stuck in the middle of something, which isn't of anyone's design. But morale is awful in general practice, I'll be honest, because the national narrative in the press, in the media, is one of failure. The government talks in terms of failure. And it's generally a group of professionals, both from reception onwards, that really care. And when they feel that they're not able to provide all of the care that they want to, they then feel that they're facing moral hazard and that they're letting everybody down. Thank you for the question, but I do think things are going to improve slowly. I can see that there are some glimmers of hope of staffing numbers increasing. I can see that we're being more productive with the people that we've got. I think the big bit that's missing is explaining clearly to others, to our population that we serve, what's happening and why, which is why we're doing sessions like this today, and we'll continue to do them as much as is required. So thank you for asking, Jan.
Yeah, I was just saying, Colin, I speak very highly about practice. It's really good. And generally, systems are good. I've got in the habit, I must admit, if I know it's not urgent, because our practice allocate appointments all day long, I phone on an afternoon when it's quiet and get an appointment in a week's time. And it means I don't become part of that 8 o'clock rush. And I don't know if other practices do that kind of thing. But because you can phone up later, and you will get.
Wendy's saying no.
It just relieves the pressure. I just think it works well. So if I want an urgent appointment, I join in the rush. But if it's just one of them things where I need to see somebody, in a week or 2 weeks' time we'll do it. Phone up on an afternoon, you're second in queue.
So I think Wendy's moving within the district to a house close to you, please.
It's probably worth pointing out as well.
Sorry.
The quality improvement tools that we talked about previously have been around for a little while, and New Southgate took part this year in service improvements and quality improvements. So some of this is getting the learning. It's really good because you're not the only person who comments on positive experiences when people have been through some of this quality improvement methodology, and the changes that need to be made are not massively complicated. Sometimes little examples like that, like you can ring up at any time, is helpful. But you are right about the demand-led sort of stuff. I'll only get one if I'm first in the queue stuff, and we'll be battling with that for 5-10 years because it's a cultural change within society.
You can tell people from New Southgate surgery, because when everybody's complaining about the doctors, they just sit quietly at back and don't say, oh, like, how was that like that?
What we need to do is to learn from what that practice have done and help Wendy's practice. Wendy, if you want to send me a message about which practice it is,
it's Firewood in Pontefract.
Fine. So there's some of the things that we can pick up. I actually think that Firewood might be going on the next cohort. But,
I hope so.
But yeah,
I hope so.
Just
Firewood, what? I didn't hear that. I'm sorry. What did you say? Firewood?
Sorry, it's Firewood surgery.
He's next to go on the quality improvement program, which is
Chris, your speak is terrible. It sounds like you're in a tank of water, and then you keep breaking up. I've really struggled all the time you've been on.
I think he's just saying that Firewood are due to go onto the quality improvement program shortly.
Right.
I've got Sean, and then I think it'll be time for us to wrap up.
Yeah, thank you.
Yeah, I've just seen in the chat someone praising Outward Surgery. I can't praise them enough. I've never ever had a problem getting through. I've never ever had a problem getting a doctor or speak to a doctor. But I changed about 4 years ago from basically my local practice, who I think even now people are struggling to get through. So I still can't get my head around why one practice can be so poor and one just literally up the road be so good. And the contrast is chalk and cheese. So what initiatives have been done to sort of take those good practices like New Southgate, Outwards, there's probably many others as well, and actually help? I won't mention the name of the practice that is obviously struggling, but I personally felt, because I was involved in a medical incident there, and in my opinion, it was badly handled, incredibly badly handled, to a point where actually it could have been very, very serious. I basically had a heart attack in the GP surgery and left in a room on my own. So how can you ensure that particular practice is supported, brought up, and brought up to the standards of Outward?
So I'm sorry to hear about what happened to you, Sean. That's not something that we like to hear. So we do it through a number of ways. So feedback from Health Watch and other groups feeds into the work that Chris and our team, myself and our team, do on individual practices. We also look at various metrics, and we go in and do quality visits once a year or once every 2 years, depending on responding to soft feedback that we've got. I think the real challenge is that is around staffing and retention of staffing. So you have a practice that's actually functioning quite well, delivering a good service, and all it takes is the loss of 1 or 2 members of staff and things can dramatically change, because it's really hard to recruit GPs and nurses at the moment. So if I look across the district, we're probably carrying vacancies of around 15 GPs. Or you can have enough GPs and then suddenly you get some ill health, long-term ill health, and maybe maternity leave. So I'll hold my hands up. I'm part of a practice that had 4 staff suddenly, 4 GPs suddenly not working because of health and other problems, and it had to dramatically change our delivery model to one that we don't particularly like, just to maintain staff some form of safe delivery of care. So it can change dramatically in the space of a week. But the most important thing is that practices are listening to feedback, are communicating with others and others about what's going on and why and what their recovery plan is. And then we have a kind of list of practices that we're wanting to put through. We'd like all the practices to go through quality improvement activity, formal quality improvement programs, but we're tending to highlight those that we're hearing they're saying themselves have got access challenges, and they're trying to ask how to do it. And that's often what happens. Practices come to us saying, can you help us with this? And we often triangulate that with what we're hearing from other places. I'd be interested, Sean, if you could kind of feed back to Tracy or Chris the practice that you're politely not mentioning, which is great, but, so that we can have a little look into that as well.
Well, Dasha knows on that one. I think we've discussed this before. I'm not trying to be negative. I personally think, because I've worked in business and we look at obviously quality improvement and it's all about working smarter. I appreciate there's the shortage of GPs and doctors and nurses, etc. But it's also the feel of the place. When I walk into Outwards, I feel very welcome. This particular practice, I've never felt welcomed. I've always felt I was a burden. When I had my heart attack, I was basically stuck in a room to wait for an ambulance. I gave them the benefit of the doubt, but actually it was listed on my medical records as having a cardiac event, which just, I mean, I still to this day cannot understand that. So it's a bit more complex than that, but I want to improve it, not to just be down on that particular practice all the time. We move practices with the presumption that, well, it might be going from the fire, from the frying pan into the fire, but actually, I really cannot praise them enough. You know, I've never had a problem. My wife's never had a problem accessing a doctor. Yes, they've got vacancies there. This other particular practice have vacancies, but you know, I think it's systems. I think it's working smarter. I think it's managerial as well. But anyway, I'll leave it there because I'll be interested to. Obviously, it's interesting. This is the first meeting I've come to. Obviously, there's a lot of initiatives within the area to improve things. Thank you.
Thank you, Sean.
Yeah, thank you, Sean. Thank you, everyone, for your input today. It's been really great to hear about all the positive and the good work that you're doing, Colin, the stuff in the background that we're not always aware of. So thank you so much for sharing that. If you can share little snippets in future with us, we can put that out via the Recovery College website and other means as well. Thank you to all the COVID champions for coming today, for sharing your stories, sending your messages. And it's great, somebody's put in the chat somewhere that it's great we are all working together to try and make things better for all of us. So thank you ever so much indeed. Thank you, Colin, for your precious time. We very much appreciate it. If there's any more comments and questions, please feel free to email. You can email them to ccc@wakefield.gov.uk. Thank you ever so much. Have a great afternoon.
Yeah, thank you.
Thank you. Bye.
Bye.
Thank you, everyone. Bye-bye.
Bye.
Thank you. Bye.
Thank you. I think we've got Manira, Lindsay.
I don't know if I leave, will it cancel the meeting now? I don't know.
Well, I'll stop recording. I should have done that